Welcome guys. In this video we'll discuss about some of the liver function test chart and we'll go in a step-by-step approach to find the diagnosis and identify the condition of the patient. Okay, so coming to this chart number 1. So what are the information that has been given to us? We are given the bilirubin value, SGPT value, alkaline phosphate, protein with albumin globin and prothrombin time. AST is not given, only SGPT is given. Now from this below above, you can find that bilirubin is raised. Bilirubin is raised with conjugated fraction more than the unconjugated fraction. ALT level is raised. ALP although raised but is near normal, as normal value ranges up to 140 above times also it raises, so it is almost near normal time. Not strikingly raised, but ALT is obviously raised. As normal value is 10 to 40, it is around more than 5 times of the upper limit of normal. Now coming to the total protein in albumin globulin part. So ratio has been maintained, like normal albumin value is 2.5 to 5.5 range, around that range. So ratio is normal and globulin ratio is normal, as AG ratio, albumin globulin ratio 1 is considered to be normal. Alright. So in first glance, what you can see is that bilirubin is the part which is markedly raised along with deranged of ALT. Alright. Now what is this bilirubin raised? Bilirubin raised, first of all, is divided into two types. Bilirubinemia or jaundice is divided into two types based on the bilirubin level, that is mild, moderate and severe. Bilirubin up to 6 is considered as mild, 6 to 15 is considered as moderate, and more than 15 is considered as severe. So this is going towards moderate bilirubinemia. Once you reach to the conclusion this is something of the jaundice, next thing that you know is to look at the fraction of unconjugated and conjugated bilirubin. It is called as indirect hyperbilirubinemia when unconjugated fraction is more than 85%. When unconjugated fraction is less than 85%, it is called as direct or conjugated hyperbilirubinemia. Okay, so this is indirect hyperbilirubinemia. If unconjugated fraction is less than 85, or that is conjugated fraction is more than 15, then it is considered a direct bilirubemia. Okay, all right. So here you can find total bilirubin is of 8.7 with conjugated of 6.3. Thing that is we are dealing with is a condition of direct hyperbilirubinemia. Now, what are the causes of direct and indirect hyperbilirubinemia? So, if you want to show the causes of the jaundice, what we usually read is jaundice clinically are of three types. Hepatocellular, that is damage to the liver cell, which causes release of bilirubin products into the system in the bloodstream, which results in hepatocellular jaundice. Then there is a jaundice of the obstructive variety, which is also known as cholestatic jaundice, and it can be pre-hepatic or which is the mostly hemolytic variety. Okay, mostly the hemolytic causes of the jaundice. Now, what are the pattern? Usual pattern. Usual pattern is in cholestatic and hepatocellular both will have direct hyperbilirubinemia. Alright, both will have direct hyperbilirubinemia, whereas pre-hepatic will have predominantly indirect, that is more of the unconjugated bilirubin raise, it will have indirect hyperbilirubinemia. Now, once you know the causes direct hyperbilirubinemia, to differentiate between cholestatic and hepatocellular, you need to look into the other markers, that is AST, ALT and ALP. AST, ALT will be reached in hepatocellular if there is liver injury, whereas almost will be near normal in case of cholestatic variety, whereas ALP, alkaline phosphate, will be reached in case of cholestatic variety, or near normal in case of hepatocellular variety. So looking at the ALP and ALT AST value, you can differentiate between the hepatocellular ones and cholestatic one. Coming back to the chart, in this chart we are getting ALP to be near normal. So, or there is, you can say, mild to moderate elevation, like alkaline phosphate is normal value if you consider to be 35 to 130, it is mildly increased. So mild increase can be parenchymal hepatic disorder as in case of hepatitis or in case of cirrhosis. Now, strikingly increased, like 10 to 10 times, 5 to 10 times raised, values ranging in 1000 to 100, 700, 800, it can be seen only in biliary obstruction. So this is not a cholestatic jaundice. It is a direct hyperbilirubinemia mainly due to hepatocellular injury. Hepatocellular injury, why hepatocellular? Because ALT level is raised. Now hepatocellular injury, that is ALT level raised, can be due in case of hepatitis. It can be of drug-induced liver injury part, alright, drug, or in case of cirrhosis. Now whether cirrhosis is present or not, you can differentiate between albumin-globulin ratio. Yes. So how does it help? Albumin-globulin ratio. If there is cirrhosis, this AG ratio gets reversed. Normal AG ratio is of 2:1. In cirrhotic patient, albumin-globulin ratio reversed. So this is maintained here. 2:1 ratio is maintained here. So cirrhosis is ruled out. So what are the other causes of direct hyperbilirubinemia with hepatocellular injury pattern? The most common thing here to be hepatitis or drug-induced liver injury. Alright. Okay. So what is the inference here? Inference or diagnosis of this case, you can say diagnosis is hepatocellular jaundice hepatocellular jaundice. Now, as this is a hepatocellular jaundice, what are the next question that you will be asked, that what are the common things that you want to rule out in such cases? Alright, okay. So obviously in hepatocellular jaundice, which maybe etiology wise one thing that you want to look, whether it is drug induced hepatitis, which are very common in clinical practice, or infective hepatitis. Infective means viral hepatitis. Okay. So as AG ratio is maintained, you can consider this hepatitis almost to be acute in nature. Okay, acute viral hepatitis. So what are the investigation that you would do, or what are the drugs that you will rule out in such cases? You should always rule out the ATT, anti-TB drugs, that is rifampicin and isoniazid use. You will rule out paracetamol poisoning. Paracetamol poisoning, that is easily range of more than 20 to 30 paracetamol tablets of 650 milligram tablets, or that is dose of poisoning to produce as a hepatocellular pattern is around 10 gram per day. Okay, more than 10 gram per day. So more than 10 gram is around 20 tablets of paracetamol. Even obviously rule out any seizure history as drugs for seizure episodes, like which was used in earlier days, phenytoin tablets or carbamazepine, even valproads are believed to produce seizure episodes. Alright. Okay. So these are the drugs that you think you should always rule out. ATT, you should rule out paracetamol history, you should rule out seizure disorder. Alright. Now viral hepatitis, what are the serological investigation that you like add on to this feature? You would obviously like to do IgM and DHAV for hepatitis A. Can hepatitis B present as acute hepatitis? Yes, hepatitis B can also present as acute hepatitis. For this reason, you will do HbS-AG, and IgM anti-HbC, that is core antigen for hepatitis B. Ruling out hepatitis C is no value in such cases because hepatitis C usually presents in chronic. So IgM HAB and IgM anti-HbC and HbS-AG will be helpful. Can hepatitis E present such picture? Obviously, hepatitis E can present into such pictures. So you should always rule out IgM hepatitis E also along with hepatitis A, that is IgM anti-HAB should be ruled out. Now there are instances of co-infection that is with type D variety anti-HDV. It is to be ruled out only when hepatitis B is coming to be positive. So anti-HDV, if it is suspected, you are suspecting co-infection or superinfection. Alright? Okay. So these are the vital markers you need to rule out for IgM anti-HAV, HbS-AG, IgM anti-HbC, IgM anti-HAV, and these are the drugs you should rule out in this case. Okay. Let's see the next chart. So diagnosis is done. Diagnosis for our first chart is hepatocellular jaundice. So what is this chart showing about? Again, you can find in this chart where we have been given a bilirubin to be raised, right? Okay. So what is the bilirubin raised at? 7.1. You can divide. We know the bilirubin raised is divided into mild, moderate, and severe. So it is again coming into the moderate hyperbilirubinemia. Now, when there is moderate hyperbilirubinemia, look into the conjugated and unconjugated fraction. Conjugated is more than unconjugated, so again it is coming to be direct hyperbilirubinemia. Now, what is the next step when you find direct hyperbilirubinemia? Next step was to look out at whether direct hyperbilirubinemia was due to cholestasis or due to hepatocellular injury. So, how to differentiate? For the liver function test as well as the alkaline phosphatase. Alkaline phosphatase again coming near normal or mildly increased. So this is not a cholestatic, and SGOT, HBT both are deranged. Therefore, direct hyperbilirubinemia due to hepatocellular injury. Now, once it is hepatocellular jaundice, you are finding to be hepatocellular jaundice. Next, look whether the etiology wise it is acute and chronic. How to differentiate between acute and chronic? Look at the AG ratio. AG ratio, that is albumin globulin ratio. So what is the normal AG ratio? Normal AG ratio is around 2:1. But look, it is getting reversed, right? As it is almost globulin is more than the albumin. So AG ratio is not 2:1. That is, synthetic function of the liver has been already compromised. So hepatocellular injury is due to chronic nature of disease. Now, once you have established that something is causing it to be chronic nature of the disease, that is whether you are dealing with chronic hepatitis or liver cirrhosis. Okay. So how to differentiate between this? In case of cirrhosis patient, AST will be more than ALT. Same goes to the alcoholic liver injury patient. So here ALT is then more than AST. So cirrhosis has not yet set up in this case. Alright, cirrhosis has not yet set up, but there is chronic hepatitis. For some reason, there is chronic hepatitis. You need to search for the cause of chronic hepatitis. And one thing is for sure that whether alcohol is etiology, no. Alcohol is most likely not leading to this etiology because in alcoholic patient also AST becomes more than ALT. It is not happening in this case. Okay. So diagnosis here coming to be chronic. Most likely this is a case of a chronic hepatitis. Why chronic hepatitis? Hepatitis because ALT, AST both are deranged, and chronic nature because AG ratio is reversed. So So what are the investigation that you like to do in this case? So further investigation, obviously look for the viral markers. Viral markers, again, no value of looking for hepatitis A. In this case, we will directly look for hepatitis B and C. That is HBs, AG, IgM, NT-HBC, and NT-HCV. These are the things that we will rule out in this case. Okay. So if I add a point that it is okay, so prothrombin time normal value is around 12 to 16. So 17 is mild range. For example, if prothrombin time in this above example was 30, question is vitamin K have any role? Any role? Yes. This is the question. Okay. Let's just find it out the answer whether vitamin K has any role in this following chart. Okay. So when do we give vitamin K? Vitamin K now prothrombin. What is prothrombin time? Actually, prothrombin time defines defect in coagulation cascade in the extrinsic path. Alright. So derangement of prothrombin time can be of various reasons. Mainly, it can be vitamin K dependent protein factor defect. Now, in liver injury, vitamin K dependent protein factor injury can be there, as well as other factor get deranged too. So, what are vitamin K dependent protein factor? Vitamin K dependent protein factor is 2, 7, 9, 10. In liver injury, 1, 2, 5, 7, 9, 10 are the clotting factors which get predominantly deranged, which lead to increase in prothrombin time. In vitamin K deficiency is also prothrombin time increases. Now, when to identify where we need to give vitamin K as a treatment option? Now, look, if there is liver injury, liver itself is not producing, there is no value of giving vitamin K. But what is vitamin K? There is a decreased absorption in the body. It is a fat soluble vitamin, right? It is a fat soluble vitamin. So, in case of this is gallbladder cystic duct and it is coming to the intestine. Okay. So, in case of cholestasis, that is obstruction of the biliary flow, bile cannot flow freely up to the level of the intestine, resulting in decreased absorption of vitamin K. Alright, decreased absorption of vitamin K. In such cases, giving injectable vitamin K will be helpful to the patient. Therefore, in case of cholestatic jaundice, if you give vitamin K, there will be relief in the patient. Whereas in case of hepatocellular jaundice, there is no value of giving vitamin K injection. Okay, alright. So there is no value of vitamin K in this case. Okay. Now, what I have said. Okay. So I have said that about we need to rule out the acute viral causes of the chronic hepatitis. Now, if these viral causes are ruled out, obviously next step we will go for anti-LKM, and AN effector. Anti-LKM and AN effector to rule out for the autoimmune causes of the chronic hepatitis. Okay. Now, coming to the third chart. So, what does this chart signify? Again, we are getting somewhere that bilirubin is raised. So, this is mild now. Mild hyperbilirubinemia as it is less than 6. Now, mild hyperbilirubinemia and conjugated is more than unconjugated, again mild with conjugated hyperbilirubinemia. Next thing to look at the ALP and AST-ALT below. Here surprisingly ALT is normal, whereas ALP is raised. Okay, so here ALP is mildly raised in these cases. ALP is raised, ALT is normal, but this is mild, not markedly raised like 10 to 11 times more than. But ALT is marginally also raised. Like ALT normal value is 10 to 40. It is also mildly deranged. Okay, so here we have got mild variety with mild conjugated hyperbilirubinemia cause where surprisingly SGPT is mildly increased and alkaline phosphate is also mildly increased. In such cases, look out the albumin globulin ratio. This is surprisingly totally reversed with globulin more than albumin. What does it signify? What does it signify now? This is a very interesting one. It signifies, so let's just go in again stepwise expression. This is a mild jaundice, total bilirubin is high, and there is conjugated hyperbilirubinemia. Now, SGPT is just elevated and alkaline phosphate is also just elevated in this case. Now, look, total protein is normal. Total protein is 7.2 gram. It is normal, but there is hypoalbuminemia. That is, albumin level normally is 3.5 to 5.5. It is low, along with hyperglobinemia. Now, what is the cause? A reversal of AG ratio, along with prothrombin time to be increased. Prothrombin time is 12 to 16 to be normal. It is increased. So, what does it signify? Chronic nature with most likely this is cirrhosis. And why we are considering it to be cirrhosis? Because AG ratio is totally reversed. Okay. Now coming back to the previous chart, if you look, AG ratio was almost 1:1. That's why we considered chronic. But why we didn't consider it to be cirrhosis? Because AST was more than ALT. But in this case, you can see that ALT and ALP is mildly ranged. That is, there is not more enough cells in the body, no more enough cell in the liver to produce ALT. So it is gone to the cirrhotic stage already. Now what to look into this? So this is direct hyperbilirubinemia, most likely hepatocellular injury due to cirrhosis of liver. Now, what are the things that you need to look into this? That why AG ratio differs here. Now, albumin, let's just come into the concept of this. Now, where is albumin produced from? Albumin is produced from liver. Alright, albumin is produced from liver, and serum globulin, that is, globulin can be alpha, beta, and gamma globulin. Now this globulin is present in the circulation, all those alpha, beta, gamma globulin. Now what happens in cirrhosis of liver? There is, in cirrhosis, there is polyclonal stimulation of the gamma cell, stimulation of the reticuloendothelial system, and which causes increased production of immunoglobulins. Okay, this is one point. Secondly, as Kupffer cell, which are macrophage present in the liver, number decreases. It cannot clear the antigens present into the liver, and globulin level increases. Okay, so as there is liver cirrhosis, first point is albumin is going to decline, and due to the polyclonal activation of reticuloendothelial system, immunoglobulin level rises, leading to reversibility of AG ratio. This is the basic behind it. Okay. Even this is a prognostic significance, as falling serum albumin in any liver pathology has a poor prognosis. Okay, so this has got a poor prognosis. Now, what are the things that you want to look for? Now, beside this case is given, and there is hyperglobinemia. If you got a case of hypoglobinemia, thing that you should keep in mind that it can be because of multiple myeloma, it can be due to hereditary, or it can be due to CLL. So if any child, if you ever get globulin level to less than normal or very low, please rule out multiple myeloma, please rule out chronic lymphatic leukemia. Okay. So and what are the causes? Then can be hyperglobinemia. Obviously, when there is polyclonal glomerulopathy, as in case of chronic liver disease, cirrhosis. In chronic infection status of the body, there will be polyclonal activation of reticuloendothelial system leading to increase in the globulin level, as in case of chronic infections like disseminated tuberculosis, malaria, or Kala-Azar. It can present into chronic polyclonal gammopathy. Autoimmune causes like SLE and collagen vascular disease can present like this. Even AIDS can present like this. Alright. Okay. Now, okay. So what is the diagnosis here? Diagnosis is direct hyperbilirubinemia, most likely hepatocellular injury due to cirrhosis of liver. Okay. Now, why we cannot consider it to be carcinoma of the liver? Now, carcinoma, in case of carcinoma, bilirubin level is almost near to normal. Okay, and alkaline phosphatase is very high in case of carcinoma status. Okay. Now, coming to this next chart, what does it chart signifies? So we have again given a condition in which bilirubin is raised. So how much it is raised? It is 5.8. Again, it is mild hyperbilirubinemia. First step. Second, check whether it is conjugated or unconjugated. It is unconjugated. Once you get unconjugated, differential is totally clear. It is pre-hepatic jaundice. I have to find the cause of the pre-hepatic jaundice. In case of pre-hepatic jaundice, looking into hostile antigen is almost no value. I don't know why this test was even ordered H-based AG. But jaundice is no value even. Okay. So coming to the other part, SGPT, check other values. It is normal. 4 to 40 is the normal limit. Alkaline phosphatase is 40 to 140 is the normal range. So it is again normal. Protein is coming to be normal range. AG ratio is good. Okay. So if you get a case of a pre-hepatic jaundice, what you need to look like the causes. The most common causes are obviously hemolytic. Now, hemolytic, all the causes of the hemolysis, that is thalassemia, spherocytosis, immune hemolysis, G6PD structural deficiency, ineffective erythropoiesis, all of these causes are causes of the pre-hepatic jaundice. Now, coming to the non-hemolytic causes, coming to first congenital one. Congenital non-hemolytic causes, there are two causes, that is, one is Gilbert syndrome, another to be Crigler-Najjar 1 and Crigler-Najjar 2. Sepsis, which is the most common causes of non-hemolytic jaundice to present as pre-hepatic pattern. Then even neonatal jaundice, when conjugation UDP glucuronide conjugation is not proper, mechanism has not yet developed, so it is unconjugated hyperbilirubinemia, neonatal jaundice. And prolonged fasting can result into non-hemolytic jaundice. Okay. So how do you come to diagnosis of this? So what are the tests that you will order if you get this chart? So if it is sepsis, your history will clinch the diagnosis. There will be history of fever, infection or source of infection might be there. TLC count will be raised. There will be temperature will be raised. So this is completely different variety. Now congenital will be from familial history might be there. All history can be from the birth even. Okay. Prolonged fasting, again dietary history, detailed dietary history. For the hemolytic part, order to rule out thalassemia or spherocytosis or immunohemolysis or structural changes. One thing that you should order is peripheral but spare 1. And secondly, G6 PD level you should order for. Okay, peripheral blood smear you should order for G6 PD level. Second, you can go for hemoglobin electrophoresis for sickle cell anemia or thalassemia. Okay, this is the approach to hemolytic jaundice. Now coming to this last chart. Okay. So what are we going to discuss? Again, in this chart we are getting bilirubin to be raised. Again, it is mild hyperbilirubinemia. This is the first point. Second point is look at the conjugation and unconjugation. Here conjugated is more than unconjugated and it is almost more than 85%. So it is conjugated mild hyperbilirubinemia. Next, look at the liver markers. Now SGPT is normal, ALP is raised. So look, this is markedly raised. Normal is 42 or 40, it is coming 1362, almost 10 times. So this is a cholestatic variety. Cholestatic variety. Alright. Okay. So what is total protein, albumin, globulin? Can cholestatic jaundice? Do you need to look at the albumin? Yes, you need to look. There are some causes of cholestatic jaundice, like primary sclerosing cholangitis or primary biliary cirrhosis, which can present as liver cirrhosis pattern also. So you have to look at the albumin globulin ratio, whether production function is normal or not. Yes, it is normal. AG ratio is normal. So it is more likely obstructive pattern with prothrombin time to be increased by 3 seconds. Okay, increased by 3 seconds. So what is this? This is a most likely a case of extrahepatic cholestasis, right? So once you know it is a cholestatic variety, cholestatic jaundice, thing you need to keep in mind whether it is intrahepatic cholestasis or extrahepatic cholestasis. Okay, intrahepatic cholestasis or extrahepatic cholestasis. Now, intrahepatic cholestasis, that is intrahepatic cholestasis, that viral hepatitis, sometimes the cholestatic variety can present as intrahepatic cholestasis, viral ones. It can be due to chronic nature, as in case of chronic hepatitis. Cirrhosis, that is primary biliary cirrhosis. Okay, it can be due to drug-induced liver injury or drug-induced biliary injury, drugs And drugs that is important one are OC pill, steroids, even erythromycin. These are the one which can cause cholestatic jaundice. Okay, drug, or it can be cholestasis of pregnancy. Now, what are the important extrahepatic causes? Extrahepatic causes are also known as surgical causes. It can be due to the gallstone, CA head of pancreas. It can be due to stricture, CBD stricture. Gallstone, that is, I mean to say gallstone impacted in the common bile duct, or it can be due to CBD stone itself, or primary sclerosing cholangitis. If you get the picture of primary sclerosing cholangitis, consider ulcerative colitis. Okay. Now, what are the history features that you should rule out in this case? History feature that you need to rule out whether there is any history of pruritus, xanthoma, bone pain or bruising. Bone pain due to vitamin D deficiency present or not, and bruising. Vitamin D deficiency because fat soluble vitamin absorption decreases, as in case of vitamin K, which leads to increase in the prothrombin time. Okay. So these are the things that you think you should rule out, and this is most likely cholestatic variety of extrahepatic because SGPT is normal and total protein AG ratio is also normal, but prothrombin time is increased here. In this case, giving vitamin K will be